Well, we made it. Chapter 4, the FEES protocol. We've reviewed the anatomy and physiology, and we've reviewed the swallowing mechanism. Now we're going to talk about doing the FEES exam, all the different steps. We'll talk about the nasopharyngeal exam, the oropharyngeal exam, the hypopharyngeal exam, the laryngeal exam, the sensory exam, and finally, introducing food and observing compensatory postures during the examination. Let's begin Chapter 4. So, we finally made it to the FEES exam. I thought a great way to start talking about the FEES is to put it in the order that I would normally do it. So, let's talk a little bit about preparing for the exam. I'm one of those people that likes to have everything set out in front of me before I get going with my examination. You know, it's ideal to have a FEES exam be done by two people, the person who passes the scope and the person who does the feeding. But I know that oftentimes in my setting, I'm the person who's passing the scope, and I actually use the patient to do their own feeding, if that's at all possible. But because of that, and because I have to be so independent, and my guess is you might have to be independent also, I like to have everything set out. These are all the things that you're going to need to do a safe FEES exam. Well, you need your hand wash, and we generally use the alcohol-free waterless hand wash in my facility. I like the table pads to put everything on. I have my gloves handy, latex-free of course. Defog, which is sometimes useful. I rarely use it, but I like to have it available. If I'm going to use topical anesthetic, I have the nasal spreaders, the long-arm tweezers, the topical anesthetic and Afrin, and my Pledgets. If I'm not going to use topical anesthetic, I don't need anything past the defog. So the first step is to figure out which side of the nose that you want to go down in your patient. There's a couple ways to do it. My favorite is the sniff test. So you ask the patient to use their own finger, plug one side of their nose and sniff, and then plug the other side of the nose and sniff. The other method oftentimes you'll see people use is to look at the septum. So if you're looking at the septum in the patient, here it is right here, and you can see if a septum is deviated to one side or the other. Obviously, you want to go in the side away from the deviation because that's going to be more open. I sometimes have problems with using that method. I like the sniff test. Another method is to use the nasal spreaders to lightly put the nasal spreader in, open up one nares and then the other, and see which area looks the most open. Then I like to have my food prep all set out. Now, I don't always use everything that I set out, but I like to have it there. So I'll have several cups, my graham crackers, applesauce. Generally, I use a mixed consistency also, like pears in liquid or fruit cocktail in liquid. I might have a honey thick and a nectar thick liquid, and spoons and straws. Usually what I'll do is make my food before I start the exam. So I'll mix some green food coloring with water, or mix it with the applesauce, and I'll put some green food coloring on my graham cracker. So once I've passed the scope, I don't have to worry about doing any mixing. Now you can see that in this setting, it's an outpatient setting. And so generally we bring in a little rollaway table, set the food up on this side of the patient because I stand on this side of the patient. I always put a towel across them, especially in my outpatient setting. I tend to be a little bit messy and I hate to drop food, especially with green food coloring in it, on the patient. You know, there was papers that came out many years ago about the use of blue dye. So we don't use blue food coloring, we use green food coloring. And the purpose of using green food coloring, as you might expect, is so that we can see the foodstuff when it's in the pharynx. The next thing I have to do is prepare the scope. So as you can tell, I've already washed my hands and donned my gloves. And what I'm doing here is putting the scope together with the camera. Here is my scope, here and here is my camera. I'm putting them together and locking them down so that they're secure. Now I'm going to get the patient in position. I like to have people sit in the position that they use for eating. Now, in an outpatient setting, when people walk themselves into your office, generally the position they use for eating is 90 degrees. So you can see that I've adjusted the headrest so that the patient's sitting at 90 degrees. If you happen to be seeing patients on an inpatient basis, that's not always so easy. So what I would do is ask the patient, the family, or the nurse what position the patient is generally in when they're eating. You want to get people as close to 90 degrees as possible for a safe swallow. I tend to use the bedside tray to set my food up on, and then we bring in our camera and our scope and our recorder into the room so that when I'm working with a patient, I'll generally have the scope, the camera, and the recorder on the left, the food in front of the patient if they're at bedside. I have the bed propped up and pillows behind them so they're as close to 90 degrees as possible, and then I get everything prepared. So, getting started with our exam. As I said, we have to determine which nasal passage to use for passing the scope. And if you're going to use topical anesthesia, I suggest you ask a nurse or a resident if you happen to be in a teaching hospital, or a physician to administer the topical anesthetic. We're going to talk about that a little bit later in one of our other chapters. Holding the scope. This is so much about examiner preference. I tend to hold the scope like otolaryngologists hold the scope, so that I'm using the scope. I'm a righty, but I tend to pass the scope, holding the scope with my left hand and using my right hand to put the scope through the nose. So I like to hold the scope so I'm gripping it and I feel like it's secure. I have my thumb on the lever on the bottom to move the scope up and down, and just resting on my thumb. It's not really, my thumb isn't really pushing on it. I see some people that have the lever in here and then they don't have good manipulation of the scope. If you want to drive the scope overhand, hold the scope with these 3 fingers and use your index finger to move the scope up and down with the lever. As I said in an earlier chapter, take the time when you're learning to do this to practice driving the scope. Just sit there, not in a patient's nose, but hold onto the scope. Get the feel of holding it securely and of using the lever to make it go up and make it go down. You need to train your brain to do this without looking at your hands.